When one thinks about how to approach a newly diagnosed patient, we still go through the exercise of deciding who would be a stem cell transplant candidate versus who might not be, and also taking into consideration comorbidities. Now, a very important consideration there is that one does not want to undertreat older patients or patients who have comorbidities, yet at the same time you want to provide them with the right dose for their current situation. For a patient who's fit, who's going to go through a transplant, more often than not, we would use a triplet combination. Nowadays, usually it's a combination of bortezomib, lenalidomide, and dexamethasone. And in some cases, particularly in patients with high-risk disease, we're now considering the use of carfilzomib as part of that frontline combination, such as we would do with a KRD-like regimen. And then, of course, that would be followed with stem cell transplant. Now, for the elderly patient or the patient with comorbidities, since we're not thinking necessarily about stem cell transplant, we're going to think about a triplet that would be used as induction of consolidation. So for many of those patients, we would treat them with something like VRD, so bortezomib, lenalidomide, and dexamethasone, and then transition to a maintenance approach. There are some patients who may not even tolerate that, so very elderly patients, patients with other comorbidities who may be a candidate for a doublet only, but that's really more the exception. I would say most patients should be receiving a 3-drug-based combination.
There are some preferred regimens that, in terms of what I use in patients who have newly diagnosed myeloma. For instance, in an elderly patient, the first thing that I assess in an elderly patient is, how much therapy do I believe they'll be able to tolerate, and what are their comorbidities? In the elderly population, I often will start with a doublet-based therapy, either lenalidomide and dexamethasone or bortezomib and dexamethasone, and add a third drug. So for instance, I'll start with Revlimid and dexamethasone and add bortezomib. So they would get RVD, a triplet, but I'll do it in sequential ways so that I can watch very closely their toxicity. The other thing, comorbidities play a big role in what we select. So patients that have baseline neuropathy, we try to avoid medications like bortezomib, which may cause further neuropathy. If the patient has significant renal insufficiency, then sometimes we will avoid lenalidomide-based therapy, and we'll use bortezomib as the first regimen. Also, some people that have diabetes or have hypertension, blood pressure that's out of control, I'll avoid steroids or really dose reduce the dexamethasone in those patients. And so I really believe that, especially in the newly diagnosed patient, it's personalized medicine, the way we start medications and the way we continue medicines and the way we dose adjust them as we treat. Frontline therapy for the unfit or the frail patients. There are regimens that we can use. There is an RVD light regimen where really the lenalidomide, the bortezomib, and the dexamethasone are markedly dose reduced. And it's really trying to give the triplet-based therapy, but give it in a way that the patient, especially this frail patient, is going to be able to tolerate it. There's a lot of dose reductions for many of the medications in the elderly frail, and I would encourage everybody to look for those dose reductions. They're online prior to starting any therapy for almost all of the myeloma medications.